My name's Paul Mason. I work for an organisation called the Cancer Research UK Clinical Trials Unit at the University of Birmingham. I'm programming team leader, not head of informatics, not head of IT. I'm actually a software engineer myself, a long-standing software engineer. Been in the trade for 20 odd years, mostly in the private sector. I spent the last 10 years in the hospital, in the university. Right, so just a bit of background. So I'm coming from a clinical trials unit. So you've got biological research units over here, okay, and then you've got clinical trials over here, occupying a slightly different land, and in many respects, as you can see from this background information, we're older, generally larger. We've got a large portfolio. They last longer. Clinical trials, minimum, even the smallest clinical trial will take 3 years. And very often they go up to about 15, sometimes 20 years in length, so they go on for a long, long time. And we've got a total portfolio of over 500 trials. So this is a big trials unit. This is really the message I want to get across here. There's lots and lots of money, the bits at the bottom, and lots of people, and we're still growing. But when we come to the IT and informatics background, okay, there's 12 of us, supporting nearly 300 people. And this is one of the problems we have in clinical trials. So Brisket, as a project, has about 5 or 6 people supporting it. I have not much more to support, a much bigger portfolio. One of the things that was mentioned earlier was that when it comes to clinical research, when you're in the land between pure research and pure clinical treatment, it becomes an engineering exercise. And mostly that is because it is very heavily regulated. Now we're regulated by a lovely organisation called the MHRA, the Medicines Health Regulatory Authority, who I'm going to come to later because they have some wonderful things to say about informatics. Okay, so for my team, we have to generate about 15 or so trial systems a year, and we do it bespoke. We're an unusual clinical trials unit. Most clinical trials units have gone out and bought an application that does that for you. Most of them have bought Infomed Macro, okay, and a few of them have bought a system called Inform, which has been bought out by Oracle of all people. And one of the problems they have is that as a consequence of doing that, they experience a lot of compromise in their operating procedures. We don't have that. We have decided to focus on quality rather than quantity. So, speaks for itself, this one does. So I started in 2002, 10 years ago, almost to the day. Oops, timing's going. And then by about late 2003, 2004, a project was proposed called Cancer Grid. Now, as you'll see, Cancer Grid a lot of the ideas in Cancer Grid are similar to the kind of ideas that are in Brisket and actually tend to go on from that. And they were sort of born out of the same kind of ideas that bore the NCI-CB, the Bioinformatics Initiative in America. It wasn't given a lot of money, whereas the NCI-CB have been given millions. There was a sister project. It was operating primary care, doing a similar kind of thing, and that had a sort of a limited degree of success. But Cancer Grid itself, it failed in its headline objectives. And from around about 2007 to a couple of years ago, to late 2010, 2011, we've done nothing. We've not been involved. And then we've had a local initiative come up and Brisket. Sorry.
What's your view about why those things failed?
I'm going to come to that. I'm going to come to that in some detail. So, what are our requirements? We need systems that are based on a well-defined methodology, and we're still trying to work that out. So 10 years later, we're still trying to work all of that out. We've got to the point, as you'll see, where we thrashed out ERDC, and now we're into sort of like the data cleaning mechanisms. We need systems that are simple and flexible. That's not only for the end users, but also for us to manipulate. And that's one of the other reasons why we create bespoke software, is because it's nice and simple for us to use. Almost everybody who's gone out and bought Infomen Macro rues the day. The IT people rue the day they made that choice, because they spend an eternity trying to get the damn thing to work the way they need it to. And this is one of the things where, if you like, the open source model comes into it. Historically, our background is open source is a bad thing, because we want things that just work. But as it's matured over the years, and as the breadth of experience and the breadth of support has matured over the years, it's become much more realistic. Ideally, we want systems that are self-describing. Okay, now that's something that's, our end users don't care about that. Our clinicians and our nurses don't care about that. That's us, we care about that. As informaticians, that's what we care about. And ideally, we want to provide end-to-end functionality. So this is your classic bench to bedside. At the moment, we don't do that. Okay, and this again is where sort of Brisket sort of fits, it plugs a nice little sort of gap for us. So, I'm not going to go through this in detail. What I really want to highlight is the fact that development in our systems is slow. So in 2000, for 10 years up to 2000, we had the most disgracefully designed Oracle database. It wasn't even relational. It was appalling. And then in 1999, one of my predecessors decided, we're going to move over to Microsoft Access-based systems, Microsoft Access and SQL Server systems. Now, you may not think at that time that was a step forward. It was a step forward, but as I say at the top, as I said on the previous slide, previous couple of slides, we were 10 years behind at that time. IT and clinical trials was 10 years behind. And part and parcel of the reason for that was because you've got this huge monolithic organisation with a massive history of data. You've got lots of legacy to deal with. You guys don't have to worry about legacy so much. And believe me, I am massively jealous of you. Okay, so it wasn't until 2004 we started working on proper ASP.NET systems. We start working on ERDC. We've only just finished the methodology for that. Yeah? 5 years, 6 years later. Okay, so bit of history, Cancer Grid, 2003 to 2006. It was an e-science initiative, and hopefully John remembers it reasonably well, I don't know. And it had this wonderful set of proposals. They wanted this bit here, I don't know if you can see this protocol design service here. That was all going to be ontology, metadata driven based. It was a wonderful idea. And then the rest of it is fairly similar to the kind of things that you're looking at in Brisket. So you've got controlled vocabulary services. You've got data collection, cleaning, management, including the NHS data set. So you've got this integration with the NHS data sets. You've got real-time modelling, real-time analysis that's involved in this. Okay, and the bit that was extra, what the clinicians wanted was they wanted a tool where they could go into a big video conference and they could do something like a sort of minority report type thing. I want some data from over there, I want some data from over here, bang it together. I want a lovely, sexy video conference suite that will allow me to correlate these data sets together. It was a wonderful image. This is 2003, bear in mind. This is 9 years ago. So what happened? Well, as you can imagine, with £300,000, as opposed to the $45 million that NCICB were given, not really much was achievable. It was too ambitious. At the time, they were going to use the NCICB metadata repositories. They turned out to be too slow. It took months to curate data items. I mean, we didn't even attempt to do the ontology development because we couldn't even get the data items in there. We discovered that in terms of clinical research, the knowledge base, the clinicians and the statisticians and the research nurses and the people who are involved in it, they just were not interested in doing that because they were saying, we've got programmers, we can do this already. You just go off and write a piece of software for me, and off we go. Yeah. Clinical trial domain is too complicated, and it still is. If we were to try and do the kind of thing that you're doing in Brisket, in the clinical trial domain, we just wouldn't. It would just suck up a massive amount of resources. The fact that you're a little BRU is actually massively to your advantage. You've got a controllable scope. Grid programming, don't get me started on grid programming. Grid programming is not appropriate for clinical research. It's best left to the physicists. It's not secure, particularly. Well, at the time, it wasn't particularly secure. And it was a nice idea, but not ready for us. The simple fact is that clinical research data sets are too small, tiny. Even now, 30 years worth of data, you're talking about less than 15 gigabytes of data. We've got more audit data than we have real data. We found that centralised systems are inflexible, and in fact, the critical thing we found about SharePoint was that large, monolithic, top-down projects don't work. We need smaller, bottom-up projects that are driven by the professionals. EPCRM was a bit more successful, same kind of thing, but it was much, much more pragmatic. And that's gone on to become the Transform project, which is an EU project, which, because it had the same fundamental basics behind Cancer Grid, has stalled because metadata-driven design of systems, design of studies is a very difficult thing to attain. The kind of retrospective tools that you're kind of applying, you've got prospective development, but it's a retrospective application. Much more successful. So what did we do next? We went it alone for quite a long time, in fact. To this day, in fact. So our systems are metadata driven. Because of the regulations, we're expected, we have to document and test absolutely everything. We have to validate every single system. And again, it means it's advantageous for us to write bespoke systems. We can just do it as we go along. We don't have to worry about complex validation methodologies. We don't have to worry about centralised OOP infrastructures because each trial system, each system is standalone. So it means we can evolve the development as we go along. And this is a little bit of a warning for you guys in the approach that you take, is that if you've got, as time goes by, you've got lots and lots of studies in your system, when you start applying changes to the functions and to the methodology later on, you can get all kinds of fun and games with how that applies to historical studies. So you do have to be a little bit careful in that particular arena. And critically for us, because we didn't have it before, we actually found some money, and that money is employed over there in that corner with family. So yeah, so the Cancer Grid ideas, most of them are still valid. They're still interesting and still interesting ideas, and if we can make it work, the net results should be useful for everyone. So we've been on the lookout for interesting ideas. And then the MHRA did this to us. Now, this doesn't apply to you because you're not regulated in the same way, but it's just a little eye-opener what might happen. Okay? Our regulator turned around to us and said, any data we pick out of NHS systems has to be validated and from validated systems. Yeah? So you can imagine validating an entire PAS system. That means documenting it, testing it, going through load testing, use testing, so on and so forth. Your average NHS trust, 99% of his operation, 99.5% of his operation is for basic operations. Tiny little bit is research-based. And in fact, I mean, they overlap massively. So they're not going to do that. And when I went to a Barclay conference in, I think it was 2009, there was uproar. They were like, you can't do that, it's madness. And they basically said, you've got to have your own systems. So if you're using an imaging system, if you want to get imaging information out of the NHS, you've got to go along and provide your own imaging system that's been validated to the same level of governance that our internal systems have been validated to. Madness, absolute madness. Can anybody tell me why it's complete madness? No. What happens now when you're collecting data? No? Okay, so basically the madness in this is the MHRA have said that if you transcribe data manually, you know, a nurse transcribing data from a computer to a piece of paper and then into a research database, that somehow validates the result, the piece of information that you are. Whereas if it's done computationally, it doesn't. Yeah? The simple fact is that all this data is being collected, it's being manually transcribed. If it was collected by a computer, what's the difference? Madness, absolute madness. The MHRA do not understand IT at all, by the way. Their head, in their inspection group, their head of data management informatics is a statistician. Now, I don't want to disrespect statisticians, but they're not informaticians and they're not IT people. Anyway, so we were waiting for good ideas, and then in 2011, late 2010, early 2011, a good idea came along. And it happens when two groups have the same idea without knowing anything about each other. Cancer Research UK have a programming scheme, have a program grant called the Stratified Medicine Programme. And our local bid for that included this particular graphic that came from the UHB informatics team, their manager, Dan Ray. And essentially, that's brisket. So bear with me a minute. You have a central repository there. Yep, data warehouse. You have your biorepository there. You have a lab here, you have NHS systems here, and you have a clinical research bolt-on there. So this is exciting. When we first came, we didn't know about brisket at this point. This came along, we were like, "Ooh, wow, excellent, fantastic." Somebody in the NHS, somebody in our trust has woken up to the reality that they need that central repository. That's the most important bit. Okay, not only because it's just sensible to pull that information out, it means that we can validate that bit. It means that activates our ability to use NHS data better. And then a year later, after all of this, we formulated a project. We found a professor who was willing to back us up with this and to promote it. We hit various brick walls with NHS infrastructure, but then you guys came along in January. Fang Min had gone to the previous conference. What was this conference? The EHI Live, yeah. She went to EHI Live last year and came back with this graphic, and I just clicked it straight away. And there you go. There's your central data repository. So we were like, ooh, we're really excited. We came round last January. And we were so there was basically myself and two of the colleagues from other trials units around the country. And we were sort of the usual sort of sceptical oh, it's another informatics project and whatever. So we walked out of there very interested and very sort of switched on to it. And that was because, A, the idea is basically a good idea. But B, from the guys, from John and from Nick and company, we got a very pragmatic message coming through. And they listened. One of the reasons why Cancer Grid didn't work was because of the people that were involved. We just didn't trust them eventually. We didn't agree with them. We didn't think they were working in everybody's best interest. Get that vibe from you guys. You actually want to collaborate rather than just using everybody else. And so good communication and listening is. And then also the fact that you're not trying to do too much too soon. You're biting off bite-sized chunks. You've obviously, one of the big things that came out in January was this whole issue about the information governance, and I think that predominantly came from our little corner. It sat in making lots of noise. Typical clinical trials unit, IT people, big mouths, little bodies. Yes, Peter's gone. Okay, so what next for us? this is not so much from the clinical trials unit side of things. We actually have a liver BRU that's attached to us, and what we do is we provide sort of we provide IT programming and statistical support for these guys from their clinical trial point of view. But we had a meeting with them last week, and they're very interested. They're actually they've got an existing set of repositories for their liver databases that go back way before BRUs were ever even thought about. But still, they're very interested in this, where we've shown them the flow diagrams and what have you. And I think there are things that you guys are doing that they just can't do at the moment. So in terms of what we've got to do is, obviously this hack event is particularly important for us and everybody here, in that hopefully at the end of it, the Brisket guys will have a better idea of how they're going to take it forward. We'll have a better idea of what we're going to go and take away to our respective institutions, and I'm guessing you guys at UCL are in that kind of boat. And then really I've got to go and then talk to my doctors, directors, my bosses, but critically I've got to go and talk to UHB and go and get them involved. Now that's not just the informatics people, that's also the biorepository people as well, and the liver BRU. And then hopefully, at some point, hopefully we'll be able to join the consortium and declare a more formal and permanent interest in all of this. Okay, that's me done. Any questions?
No questions from anyone? Well, thank you very much, Paul. That was great. Oh, sorry, Tony, my apologies.
Oh.
In some ways my question feels rather silly given everything you just said, but I'm just interested in terms of more of a technical question about why some of the previous efforts didn't work. You've done a lovely summary of that, but I just wonder to what extent the challenge of getting the data into the system is one thing that you didn't really focus on, because especially if it's you've got control vocabulary and quality involved, and you've got validated data, and there's many sources of information. To get it actually curated, up to right quality, all suitably structured and then into the system, that seems like, something that we build the systems, we assume someone's generating data, but that's a bit easily overlooked.
There's two aspects to that. It's two aspects to answering that. One is cultural, and it's to do with clinical trials and their history, and the way they see informatics. And the other one is pragmatic. So I'll start with the pragmatic one, the technical one. So back in 2005, let's say, we faced two, I suppose, critical problems. We didn't have the kind of tools with respect, all the knowledge base with respect to curated metadata that you guys are taking advantage of now. There was less understanding that curation needed to be a much speedier affair. They were kind of focusing on the methods of doing it and focusing on if you like, the theories and the practicalities around using metadata. They weren't really thinking about how anybody was going to use it in the real world. We were kind of part and parcel of the feedback that means you guys have got better tools. So it's one of those things, it's kind of right idea, wrong time. I think the other problem we had as well was the software engineers we were dealing with they were kind of too academic, and they were too focused on just playing with the latest tool. They basically brought their own baggage with it, which was this kind of concept of model-driven functional programming. And it's fine if you've got a nice stable model to work with, but clinical trials presents a very poor model. It's very fluid, and they just tried to sort of chew off more than they could. The simple fact is that protocol-driven, endpoint outcome measure-driven curation of metadata is not really necessary. The human brain can do that far better than a computer can do it, to be quite frank. So it's one of those things that they just tried to sort of bite off more than they could chew with a limited number of resources. And to be quite honest, the people that we were dealing with didn't really listen to us. We're saying, look, this is in classical system design, you start you start your design at the end. You start with the output and you work your way backwards. And that's what we tried to get them to do, and they just were not interested in that. The other side of it is cultural, and that is in clinical trials, and this kind of goes back to the start of the slides, is that informatics IT is a bolt-on. It's not we're not part of clinical trials. You go over here, give your programmer a CRF, say just go and do it, yeah? And it's very, again, I'll go back to my statisticians, it's very driven by statisticians. Whereas for you guys, you've got a bunch of clinicians who are interested in analysing lots of different types of data, and they are going straight to an informatician and having a direct relationship. I've never, and I mean in my entire professional career working at CICT, I've never had a meaningful conversation with a clinician about any of the systems we've built. That not only are they not interested, they are, even if they were, they just switch off, you know. But anyway, yeah, that's the...
Those are all great answers, and I'm not disagreeing with anything you said. And I think it's great that you're praising the general approach of brisket, even involved with listing and all that. But I just wonder whether brisket or your systems or any other systems, even though we seem like now that we've made all mistakes in the past, we know a much better way of approaching all this, have we to date really got evidence that the system is possible to populate with the right quality of data at the pace we need to have it going? And if anything, I'd argue that's perhaps one of the real strengths of brisket, that we're putting a lot of attention into that level of tooling.
Yeah, I mean that's what we're interested in as well. Is, you know, can we develop brisket style tools in the kind of timescales that are needed? So we've kind of, well, hopefully we've brought an existing data set, an existing example study to the HAT meeting that we can try and work through. Now I know how long that took to program as a bespoke standalone database that has not a self-describing system in any way, shape or form. And we can even show you it. If we've got network access, we could log on and actually show you it right now if you wanted. But it's one of those things where we just don't know at this moment in time. We literally don't know. But that's what I'm hoping to gain, at least, you know, a window into that between now and Christmas. Really, that's what I want to try and get to. And I assume that's what John wants to try and get to.
Is it on? So what led you to choose SharePoint? That's an interesting choice.
No. We didn't choose SharePoint. SharePoint was chosen by the CanScrid people. It was just something they play with.
Sorry. Yeah.
And it is quite interesting actually, because there is SharePoint in theory should be a wonderful tool. It is a collaborative tool, and it should be wonderful to host all the sort of the management information kind of functions that you get in clinical research, contacts management, data collection. There's an interesting system put together by the Veterans Association in the US that used SharePoint, and they did some demos for us in 2006, and it was fantastic. It was lovely, until they told us how much money they'd spent on it. Millions of dollars, and because it's US military, they've got that money to spend, and we were like, okay, fair enough. But CanScrid, actually, the group in Oxford, they still exist. They're still sort of peddling the software that they have produced, and it is still SharePoint based. So there's a bit of it that's sort of still working, but it just didn't, you know, it just didn't add up for us. Money, anyway.
Hesitant about taking up any more of the afternoon, but I think there's a thing that from a brisket Leicester point of view it's worth asking. You talk about our spirit of pragmatism, and I think following your contribution at the last of these events, I think we were pretty clear that one of the things we needed to do was define our boundaries and say there are certain things that brisket's got a focus for, and there are certain things that it probably isn't. Mm-hmm. And we probably put clinical trials units on the outside of that.
Yeah, absolutely.
So for the regulatory reasons and the nature the kind of data environment that you're having to work in, that may not be, we're just not going to try because we don't want to try to take on more than we can handle. But what you've talked about today seems to reopen that dialogue a little bit and say, well, the situation facing CTUs is you're still looking for informatics solutions that operate in the same field as brisket. So I suppose the question I've got is whether you think that we should continue with that approach of saying that's outside of scope and brisket will continue to deliver for translational and academic research but not trials, or whether you think we should review the brisket tool set and begin to think about which, if any, of the elements might be CTU appropriate.
My immediate reaction is that you should avoid clinical trials like the plague. Although clinical trials units in informatics terms are still sort of operating largely in the dark ages. We are, it's something that works for us. I think, to be quite honest, eventually there will be a natural evolution, because the biological research units are still quite young, and there's been quite a wide interpretation of what the BRU funding is about. We've taken the view at Leicester that it's about infrastructure, whereas in Birmingham our liver group have taken it as we can do lots of projects, and they've not really worried about the infrastructure because that's what my team provided, amongst others. So it's one of those things where I think as the BRUs, as they progress, that translational medicine, in theory, should translate into clinical trials. And I think things like brisket will evolve with it. I think this is where hopefully we can add something to the party. Is that as you go along, we can explain, okay, if you try and do this particular function in a CTU, these are the kind of hurdles you're going to have to jump. And so you can kind of bear that in mind. You don't necessarily have to sort of jump those hurdles. One of the things that's quite interesting in the clinical trial world, there's been this discussion about systems, okay, and actually everybody's had to step back, because actually the problem is not systems, because writing computer systems is dead easy, okay. The discussion is about methodology. It's about how we do things. And the variation in how we do things. Even within one clinical trials unit, there is quite a great degree of heterogeneity. One of the differences between a clinical trials unit and a biological research unit is, although it shouldn't be, is that in a clinical trials unit we have very extensive procedures surrounding data cleaning. So one of the things that's been mentioned, we've all talked about data, building blocks of data and the like. Nobody so far has talked about the provenance of that data. What's the quality, what's the background? Has anybody checked whether that data is actually useful? And this is quite a critical piece of information, because even just simple, basic sort of spelling mistakes can cause significant errors in data sets, certainly when you're talking about hundreds and thousands of people. So it's one of those things that, that kind of, once we've kind of got our act together in that particular area, hopefully we can translate some of that knowledge across, because then we can say, okay, well, we've kind of done that bit, and we know that is good practice, and it's a controlled good practice. It's not something where you're going to go up to Newcastle and somebody's going to be doing it totally differently. So because of the regulation, you're probably, because of the NHS constraints, you're going to have to go through the information security aspect of validation. But it's whether you want to sort of head through it, because that's really where it all boils down to. As soon as you start dealing with clinical trials, you're talking about the MHRA, you're talking about validation. And it's not necessarily a bad thing to do. Good practice is to document and test what you're doing. So.
Paul, thank you.
Thank you.